This is Dr. Mirza Iqbal, one of the postgraduate diploma students from University of South Wales. Today, the topic of my presentation is awareness on prolactinoma. So let's discuss about this endocrine tumor. So, pituitary tumors, this prolactinoma is one of the most common form of pituitary tumors, and it makes up roughly 40% of all pituitary tumors. It generally targets females of childbearing age, and it most commonly, the peak is between the second and third decade of life. It has a female to male ratio of 10:1. Let's come to the cause of it. Majority of these tumors occur spontaneously. However, few of them do have a genetic basis which affects the AIP gene. It can occur sporadically, or it can occur as a part of a complex syndrome called as multiple endocrine neoplasia syndrome. All those patients who are presenting in young age, less than 40 years of age, we recommend to screen those patients for the AIP gene and multiple endocrine neoplasia syndromes. Coming to the pathophysiology of prolactinomas. We know that the secretion of prolactin is normally inhibited by a hormone secreted from hypothalamus called as dopamine. So the secretion of prolactin is normally inhibited by dopamine. In prolactinomas, it causes a disruption of the secretion of dopamine, and it results in release from the inhibition of dopamine and results in excess production of prolactin. And this excess prolactin in turn causes clinical manifestations by suppression of sex hormones, which we would cover later on. So you can clearly see in this diagram that the prolactin is secreted from the anterior pituitary, but it's regulated by dopamine, which is secreted from the hypothalamus. Now coming on to the classification, prolactinomas can be broadly classified based on their size. Prolactinomas which are less than 1 centimeter are classified as microadenoma, and prolactinomas which are greater than 1 centimeter are called as macroadenoma. In this picture, you can clearly see a microprolactinoma, which is less than 1 centimeter, and it's located right beneath the optic chiasm. And in this picture, you can clearly see there is a macroadenoma, and it's more than 1 centimeter, and macroadenomas generally cause compressive symptoms we would cover later on. Clinical presentations of prolactinoma. So the most common presenting features of prolactinoma are sudden headache, syncope or loss of consciousness, vomiting, fever, and visual impairment. In females, the features are galactorrhea, menstrual irregularities, and infertility. In males generally present with features of hypogonadism like reduced libido, impotence, and infertility. Patients who present in the late stage are generally the ones with macroadenoma, and they present with compressive effects like visual disturbances, ophthalmoplegia, or headache. So coming to the diagnosis of it, the most important investigation we would like to do to screen for prolactinoma is measuring the serum prolactin levels. In prolactinoma, these levels are usually more than 5,000 milli-international units per liter. However, there are various other causes of raised prolactin levels which we should bear in mind to differentiate from them. To further confirm our diagnosis, we would like to have an MRI of the pituitary gland with gadolinium enhancement, which would further confirm our diagnosis, and we would also like to have a visual field examination. So the differential diagnosis of raised prolactin levels, the most important one is to differentiate from non-functioning pituitary macroadenoma. In this, there would be raised prolactin levels secondary to uh, a large pituitary mass which is compressing the stalk of the pituitary gland, but the levels would usually be less than 2000 milli-international units. Second most important cause is drug-induced hyperprolactinemia. There are various medications that can result in raised prolactin levels. Uh, Few of them are antihypertensive agents, antipsychotic agents, gastrointestinal drugs, antidepressant agents, and opioids. In drug-induced hyperprolactinemia, once the offending medication is stopped, the prolactin levels goes back to normal. The third most important cause is primary hypothyroidism. In this, the patient would present with classical signs and symptoms of hypothyroidism like weight gain, cold intolerance, uh, dry skin, constipation, and the thyroid functions would further confirm our diagnosis, and levothyroxine would result in normalizing of prolactin levels. Renal insufficiency causes raised prolactin levels due to decreased creatinine clearance, and pregnancy again is a cause of raised prolactin levels. Polycystic ovarian syndrome would present with signs of hyperandrogenism like acne, realization, raised BMI, and raised testosterone levels. Coming to the goals of treatment. So our aim is to suppress and normalize the prolactin levels, restoring ovulation in women, and normalizing testosterone and sexual function in men. Coming to the treatment options, patients generally who are asymptomatic, having a microprolactinoma with normal menstrual cycle, and those who do not wish to get pregnant can just be monitored for development of new symptoms. All other patients can be offered these four options. The first one is dopamine agonist. Dopamine agonist has shown to cause reduction in the prolactin levels as well as reduction in the tumor size, shrinkage of the tumor. So the options are we can give cabergoline, we can start with 0.25 to 0.5 milligram once weekly, or bromocriptine 2.5 milligram once daily, and we can increase the dose by 2.5 milligram. The second option is combined oral contraceptive pills. The third option is transsphenoidal surgery. It is reserved for those patients who either fail to respond to the medical treatment or those patients who are unable to tolerate the side effects from the medical treatment. The fourth option, cellular radiotherapy, is generally reserved for those patients who fail medical or surgical treatment. Coming to the monitoring, so we should have a periodic measurement of serum prolactin levels. We should have a pituitary MRI every year to assess the size and other features of the tumor, pituitary tumor. Patients should undergo regular visual field examinations and echo for patients using cabergoline as it is associated with valvulopathy. The prognosis, uh, prolactinoma generally follows a benign course, and it progressively improves while the patient is being medically treated. Excuse me. Continuous treatment with large doses of dopamine agonist will result in shrinkage in the size of tumor, normalization of the prolactin levels, and rapid visual improvement. And treatment may be withdrawn after several years without tumor recurrence. So this is briefly we have covered prolactinomas today. Thank you.